welcome to our webinar that is starting October the 9th, 2024. It's our pleasure to be introducing Dr. Erin Courtney, who is going to be speaking to us today about becoming a vaccine super communicator. So the first thing I'd like to do is just start with a land acknowledgement. I'm calling in from Toronto, and this is in the Dish with One Spoon territory that I'm honored to be able to and privileged to be able to be living here. And this is a treaty between the Anishinaabe, the Mississaugas, the Haudenosaunee, and it bounds them together to share the territory and protect the land. Subsequent nations and peoples, Europeans, and all newcomers have been invited to this treaty in the spirit of peace, friendship, and respect. For the rest of you who are here today, welcome to this webinar. And I would like to invite you to please put your land acknowledgement into the chat, and we'll be able to take a look at it and see where everybody is coming in from. This webinar has been generously supported from Merck, and it's from an unrestricted educational grant. After the webinar today, all participants are going to be receiving an email, and it's going to be to complete a survey just to get some feedback from all of you after the webinar. And you're also going to be getting a certificate of attendance, and you can keep this for your own records and fill it in on your own and to show that you have attended this webinar. The webinar is going to be recorded, and it's going to be archived on the CHNC website as well as on our YouTube channel. These are the strategic plan for CHNC, and we have three main objectives. The first one is to advance the health of people in Canada. Number two is to strengthen CHNC as a center of excellence in community health nursing. And number three is to build an effective organization. So this is our speaker for today. We are so pleased to have Erin come back. She was at our conference back in April and gave us a wonderful presentation at that time. So Dr. Erin Courtney is a registered nurse, has a master's in adult education and a doctor of education in educational leadership. She has over 20 years working in public health, and that includes 8 years working at an infectious disease prevention and control program. She's a professor in the Bachelor of Science of Nursing program at London College, as well as an assistant professor in the Doctor of Education, Educational Leadership program at Western University. Her research focuses on vaccines and science communications, and she is the author and the lead editor of the very first ever Canadian public health nursing textbook. It's going to be published in 2025. And as a matter of fact, she just said it is going to be off to press this Friday. So that's very exciting news. As a little bit of housekeeping, if everybody could just keep their microphones muted during the presentation, we are going to be having some time at the end for some questions and answers. And Mei Tao is going to be helping us moderate the questions at the very end. So without further ado, I am going to pass this over to Erin right now. Thank you.
Thanks. Right. Just going to share my screen. Oops, I'm going to go back. Okay. All right. Well, welcome everyone. I am delighted to be here. It's one of my, my favorite thing to talk about is vaccines and HPV specifically. I am delighted to be here. And I want to also thank you for taking time out of your busy schedules to attend this webinar. I noticed in the chat, BC, Newfoundland, Alberta, Ontario. That's wonderful. Thank you. All right, so let's jump right in. Okay, so there's a few, I have some few 4 objectives for you today. But really why this cute puppy on the side here, this is Lewis. And sometimes when we work at home, there's a little bit of barking that might happen once in a while. So just in case, if there is barking, it's Lewis. So a few disclosures that I have received honorariums in the past from Pfizer, Sanofi, and Merck. And I have received educational grants from Pfizer and Merck. Okay, so To begin the presentation, I really want to introduce you to my best friend. So this is my best friend, Mandy, in the middle. We've been best friends since grade 9, and her husband of 25 years, this is Tim, and then her 2 boys, Connor and Aiden. And about 6 weeks ago, Tim was diagnosed with head and neck cancer. And based on his age, 57 years old, and also his sex, male, we can guarantee, and that he doesn't smoke and drinks occasionally, we can be guaranteed that it is related to HPV. So what do we know about human papillomavirus and or HPV and cancer? So human papillomavirus is the most common sexually transmitted infection. In fact, the majority of the population will be exposed to HPV at some point in their life, because there's over 100 different serotypes, and the majority of them, they don't cause any disease in the human. The immune system just cleans them up and takes care of them. But there are a variety of serotypes that can cause genital warts. So there's 2 different ones. And then they can also cause different types of cancer. So when we think about HPV and cancer, well, almost all cervical cancers are caused by HPV. In fact, globally, about 100% are caused by cervical cancer. HPV is causing cervical cancer. And so we did start to see a trend down in cervical cancer rates, but because of the pandemic and people not vaccinating people and people not being tested or treated, the cancer rates we're starting to see and can predict that it's going to increase about 50% between 2020 and 2040. So that's unfortunate. Now, when we talk about head and or other types of the non-cervical cancers, so nearly 2/3 of HPV-associated cancers are non-cervical, which means anal, penile, vaginal, vulvar, and the majority of non-cervical cancers are actually head and neck cancers, with oropharyngeal cancer being the most frequently HPV-associated cancer. So when I get more specific, sometimes we hear head and neck cancer, sometimes we hear oropharyngeal cancer, and really, what's the difference? Well, head and neck cancer is anything from the mouth to the base of the neck, basically. So that includes like the oral cavity. It also includes the larynx. But the majority of cancers that we see in head and neck cancer are oropharyngeal, and that's why typically you'll hear oropharyngeal cancers. And that involves the back of the tongue, the oropharynx, and then in the neck. And so when we think of Tim's cancer it's actually in the back of the tongue. And he has a spot on his neck, and that's what brought him to the doctor. Was he had a lump in his neck. So let's talk about who are these men. Okay, so males, more specifically, are 4.5% higher incident rate than females to get head and neck cancer or oropharyngeal cancer specifically. And so when we think about who are these men, okay, when we think about who they are, so we have where we see the peak of when head and neck cancer, when they're diagnosed, is between the ages of 25 and 35 years old, okay? And then that's the first peak. And then another peak happens at 55 to 65 years old. Okay, so let's think of who are these people, right? So you have a 25 to 35-year-old male. We can almost guarantee they're not vaccinated they're not vaccinated. We can guarantee that they weren't vaccinated in the school, because 2006-07 is when HPV vaccine came into the schools. It was indicated for females only. So and the people that, for that first year are 30 years old. So we know that this is why we're seeing this first peak, because these people are for sure not vaccinated. And then they're also married and or maybe divorced, and really they don't really go to the doctor, right? Why do they go to the doctor? They go to the doctor because they're bringing in their kids for vaccination. So that's, they're kind of one of the forgotten groups of patients that we can think of. And then when you think of 55 to 65-year-olds, HPV is not on their mind. First of all, they're almost guaranteed not vaccinated. They don't even probably know what HPV is. They're more worried about, why do they go to the doctor? Well, probably they're worried about shingles, maybe their erectile dysfunction, maybe they're worried about pneumonia. And so that's typically what brings them to the doctor, and it's not because of head and neck cancer. The treatment costs, when we think of what is this economic burden, it's over double. So this is diagnosis to treatment. Okay. It's over double if we're talking about head and neck cancer comparatively to cervical cancer. And then when we think, unfortunately, one other piece is that it is the #1 cancer of suicide. So people who have head and neck cancer are double likely to commit suicide than any other type of cancer. And the reason for that is, if we think of the quality of life and the morbidity that goes along with any head and neck cancer, it's extensive. If Tim, for example, this is his words to me, they cleaned me out from the hairline to the collarbone. And so he has this huge scar on his neck, but the problem is, one problem is that it's going to take over a year for him to get the function back in his arm. And then he had a piece taken out of the back of his tongue, and he still can't eat solid foods right now. And so there's a lot of weight loss, and that goes along with that. But then if we think of others who have oral cancers, right, the disfiguration that happens with surgeries around the mouth, it's really impacts, again, the quality of life. And so again, these individuals end up ending their life, unfortunately. Now, and another unfortunate piece is there's no screening for head and neck cancers, unlike cervical cancer, where we have the pap test, or now there's your self-administered pap test. Now, we're with cervical cancer. Now with head and neck cancer, there's no screening, but there is prevention. Now, we know prevention is key, okay? And I don't mean, what is the prevention? Of course, it's Gardasil 9, it's the HPV vaccine. And it's not the vaccine that's actually the prevention. I like to be clear. It's actually the vaccination. And so, when we think about, talking about the vaccine, we want to kind of shift that lens a little bit on the language and talking about the vaccination, and the vaccination. And so it also is important on thinking about those forgotten groups, and specifically around head and neck cancers. So about NACI, the recommendation for HPV vaccine was updated in July. Now, their recommendation is now for 9 to 20-year-olds, a 1-dose vaccine schedule, which there is some, we can get into that in the questions later if somebody has wants to, a little bit more information about it. But there is, a 2-dose schedule can be considered. And I do know that in my jurisdiction around here, our public health unit is choosing to go with a 2-dose schedule for the school-based vaccines. So, that's up in the air. And then really 21 years and older are 2-dose schedules. That's for NACI with no upper age limit. So let's think more specifically. Okay, so who is this vaccine for, right? Part of the school-based program, depending on what province you're in or territory, is what grade it's given in. And so, sometimes there's some nuance or some discussions that we need to have around that, because they're a little scared about getting the vaccine to the young population. But the great piece is that it is given in the schools. Now, the uptake's not the greatest, except for Newfoundland. Congratulations. Whatever you're doing, just keep doing that, because amazing. The other provinces, we're kind of like lagging quite a bit in the uptake, but really, that is a group that we do have access to work on specifically. But really, when we think of who else should we be promoting this and increasing awareness and education to, it's everyone over the age of 9 years old. So we think of like our healthcare workers, right, as specifically, I tell my students in the lab, if you're going to be around anuses and vaginas and penises and oral cavities, you really need this vaccine, because we don't really know the exposure for being around when you're really close and personal to somebody's urethra when you're inserting a catheter, right? We don't know what the exposure rate is for healthcare workers. We focus on and ensuring that our healthcare workers we got the hepatitis B vaccine. We make sure that they have Hep B vaccine. But when you look at what's the risk for someone to acquire hepatitis B, which the hepatitis B vaccine is also an anti-cancer vaccine, to the risk of being exposed to HPV. They're way, 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 way more likely to be exposed to HPV than they are to hepatitis B. So, to maybe think about that for yourself and or your colleagues and other healthcare workers. And also we want to think about, everyone over the age of 9, as Nassi says, there's no upper age limit. The oldest person that I've heard of to get the HPV vaccine is 74. So we think of, snowbirds, right? What if they're headed to Florida, hopefully not in the next few days, but if they're headed to Florida, when they're getting their flu shot and pneumo and whatever, it's HPV vaccine is a good idea as well. All right, maybe your next question is it too late, right? Do the people still benefit from HPV vaccine, even if they were exposed prior? So even if somebody has had, for cervical cancer, say they've had a LEEP procedure, so we know that they've had exposure and disease from HPV. Even Tim, right? The males, Tim clearly has exposure and disease from HPV. And that's for anybody, even if they don't know, right? Is it too late and can they still benefit? And the answer is yes. So there's been some real great studies done recently about natural protection against HPV and previous exposure. And so when we think about, let's think of chickenpox, right? Varicella, you get exposed to varicella, your immune system makes these great antibodies, and the T cells, they have this great memory of it. And so if you usually don't get chickenpox again, right? If you're exposed to chickenpox, you're safe, right? And so when we think of that kind of natural protection with HPV, that doesn't happen. And when the data or the research looks at specifically the serotype 16 and 18, which are the majority that cause cervical cancers and majority cause head and neck cancers, the females seem to have a little bit better protection antibodies against if they've had previous exposure to once they get the vaccine, and what's the exposure look like afterwards. But males, actually, there's no protection found. So regardless of exposure or history, super, super important to make the patients aware about the vaccine and vaccination. Okay, so what do we do as healthcare providers, right? What is our job now? Well, really, the number one reason why somebody doesn't receive the HPV vaccine is because A, they weren't offered the vaccine, and B, they didn't even know about it. And so the data are very clear to say that's the problem, is that people don't even know. And I think sometimes people get a little bit nervous about having the conversation because, then are they assuming that their client has, sex with random people or that sort of thing? There's, what's that story that they're telling themselves, that why they're going to kind of hold back on having that conversation. But really, that's where we need to go, is we really need to start having these conversations about just introducing the awareness, right? Most people, especially with Tim, when I tell people about Tim, I say, he's been married for 25 years, like, it's pretty crazy. And they're thinking, wow, like I never would have thought that that's something that I would have to worry about, right? And so just to even start these conversations, us as healthcare providers, that's where we need to start. So back in April, as Barb said, I was at the CHNC conference and I presented my 4C framework that I'd like to use when we're talking about and addressing vaccine hesitancy. And really, I'd like to expand that a little bit more in saying addressing HPV vaccine hesitancy, but it's also just addressing and making and increasing the awareness and education about HPV vaccine and head and neck cancer. And so I'll go through all 4 of the C's, but I really, really want to focus on 2 of them, one being compassion and the other being the connection piece. And I really want to dig into the science. Why do we care about compassion? Why do we care about this connection? What does it mean when we're talking about vaccines to other people, right? And so we can use this. You can put yourself in having a conversation with a family member, with a friend, or within your clinical setting, right? All right, confidence. So we'll start with confidence. Who doesn't love Fräulein Maria? Whenever I say the word confidence, I can't not think of I Have Confidence song from Sound of Music, but anyhow. And really what confidence is just starting that conversation, right? Having the confidence to just bring it up, at any time. And it's, and when we bring up the conversation, we're using announcing or we're using presumptive language. So what that means is instead of just saying, do you want the vaccine today? It's I have a vaccine for you, right? So you're going to presume that they're going to get the vaccine, right? As presuming that you're just asking the question, you're announcing or you're presumptive. And the data are very clear on that it works very, very well when we're talking about HPV vaccine and actually about flu as well. So this is something, say flu season's coming up, right? It's October, flu shots are going to be starting. It's like when people are coming in, you're going to presume that as they're there for their flu shot, perhaps this is where you can say, I have another vaccine for you too, as before you go to Florida, right? And so that's having the confidence. It's also about giving your strong recommendations. The data is very clear still saying, even though we know that the vaccine hesitancy rates are going crazy high, unfortunately, the data still show that the healthcare providers are still the #1 resource for vaccine information. So very important to still know that they actually trust you. And so having the confidence and bringing it up, and maybe they'll shoot you down. Okay, whatever, but at least you're making it part of the conversation and bringing it up. All right, so let's talk about compassion. When we talk about, as we're healthcare workers, yes, we're compassionate beings, but I know a lot of times, we talk about saying, oh, as a nurse, you have to be empathetic, you have to have empathetic conversations, empathy with your clients and all that stuff. So why did I pick compassion as opposed to empathy? And so this is where we look at, okay, what is empathy, right? When we think of empathy is, feeling with people. It's putting yourself in somebody else's shoes. So you're identifying, with someone else's situations, with somebody else's experience, their perspectives. And it comes from a place of fear, actually, where you're almost, I don't want to say petrified, but it's like, oh gosh, what are you going to do about that? Like, oh, I'm so sorry to hear about that. And, and it kind of stops there. Some scholars will say there's only two emotions. There's fear and there's love. And so whatever stems from fear, things stem from fear, or something stems from love. And so empathy stems from fear. Now, compassion involves empathy. You have to be empathetic in order to be compassionate. But what compassion has is it involves wisdom. Okay. And so this is where, as a healthcare provider, you need, you take action from the empathy that you've learned. Okay. You understand their feeling and where they're coming from, and you take that and you're going to help them and support them and do something with it. Right. So it really is you have knowledge, skills, and ability to support people who might be vaccine hesitant. So that's why it's the word compassion. Okay. Now, when we think of, okay, so now what do we do? Really, we need to become a good listener, right? To be a great super communicator, you have to become a good listener. So it means, the irony is that communicator, you think you're going to be talking all the time, but really it's sitting back and becoming and listening. And so sometimes when you're engaging in conversations, and whether it be about vaccines or whether it be with your partner tonight over dinner, are you listening to respond? So do you have that rebuttal? They're saying something about vaccines, or your partner was saying something, and you have that rebuttal and you want to just jump right in. So you're listening to respond, or are you listening to actually understand, right? You're understanding, what's this conversation about? Okay. And so what comes in, maybe some of you have, I like to talk about these 3 different types of conversations, but maybe some of you have children, and you read a parenting book, or you read or you took a parenting class, and you deal with tattling, right? And so what is tattling? Tattling, when they say, okay, when the tattler comes in and you say, all right, do you want to be heard, helped, or hugged? Okay. And that's what we say to the child, right? Do you want to be heard, helped, or hugged? And I'm not, saying that our patients are our children, but I'm saying what the underlying underpinning is of that is, what type of conversation is being had here, right? So if they're being, do want to be heard, helped, or hugged, heard is relational conversation. What's a relational conversation? That's your social conversation. That's, oh, I just finished reading this book. Did you watch, Bridgerton, which is so great. I highly recommend. Did you watch Bridgerton? Those sort of social kind of conversations. And then there's the practical conversations. So that's being helped. This is where, what's for dinner? Who's picking up the kids? In vaccine conversations, it's, do they need information, right? Do they need to know, how much does this vaccine cost? Am I covered? How many shots is it, right? Do they need, tell me about this vaccine. That's the practical conversations, right? So when you think about, when you're having these conversations, start with, okay, is this a practical conversation or is it an emotional conversation? An emotional conversation, that's where a lot of the vaccine hesitancy conversations lie, because it can get very emotional, right? And so really the principle is to match your patient or match your person that you're talking with. And so if somebody asks, they're an emotional, part of their conversation is an emotional, and you try to match them with a practical by giving them evidence and data and science, they're not going to match. Okay. And so there's going to be a mismatch, and the conversation they might just, disengage from the conversation. And so ultimately it's looking at, how do you match the conversation? This is where compassion comes in, right? Part of compassion is understanding what conversation we're having right here and then matching it. Okay. Couple points about emotional conversation. One is like identifying the patient or the client's feelings, right? Like, oh, I can sense that you're really upset right now, because if they're not upset, no, I'm angry. Oh, okay. They're going to tell you that they're angry. Okay. So sometimes just identifying feelings is really important. Stay away from fear, shame, guilt tactics. Of course, that's poor communication, and it will only they only will have bad results from that. And also stay away from humor. And so what that is even individuals who are vaccine, they want the vaccine. If you start with humor, it actually will make them question if they want the vaccine, and make them more hesitant. And I believe it's because, if somebody's nervous, so if a provider is nervous and they use humor to help with being nervous, then the patient's going to be like, I don't know if they even know what they're talking about. So that's why to stay away from humor. It's not a funny time. It's not a time to be funny. And then it's ask permission. And so that's where is it okay if I give you some more information? Is it okay if I ask you a couple more questions? Is it okay if, right? And so what you're doing is you're bringing the person into the conversation, right? And you're using that compassion, like, let's get to the bottom of this. Now, as healthcare providers, I can't not talk about compassion fatigue. And, sometimes these conversations they're very draining. And when we talk about, people talk about burnout a lot, right? But compassion fatigue is a special kind of burnout. Burnout is more accumulative, right? It's like scaffolding and accumulative. Whereas compassion fatigue actually could be after, one intense session with a client. But it's really focused on the caregiving profession. So the people, when you're looking after somebody, so it doesn't necessarily mean it's a nurse or a healthcare provider. It could be somebody looking after, a sick parent or something. And so we have to think about our own self if we're engaging in these conversations and it's really draining us at the time. We have to step out and say, okay, I need to take care of myself, because it's like when the oxygen comes down, put them on first for you before you can put them on anybody else. It's kind of like that, right? So, using your own motivational messages, relaxation strategies, taking a deep breath before you go into a room and you're thinking, this is always going to be a stressful client. And also another part of compassion fatigue and taking care of yourself is actually coming to webinars like this, right? Where you're getting prepared through education and just increasing your knowledge. So let's dig into connection a little bit. So now that we know about compassion, let's talk about connection. And really, connection has everything to do with uh, social identity and storytelling. Okay. So let's talk about, oops, there we go. Let's talk about social identity. What is social identity? What does it matter, right? Social identity has everything to do with belonging. And so, historically or evolutionary wise, you have to belong to a group. If you don't belong to a group, you're ostracized. That's the worst thing that could happen to you because you're more likely to die out in the wilderness if you don't belong to a group. And so people need an identity. They have to have a social identity to belong to a specific group, right? And ultimately, we have multiple identities, depending on the context that we're put into. And so let's just use, for example, you're going to a PTA meeting, okay? So at the PTA meeting, you're not a nurse, you're not a professor, you're not so-and-so's husband, so-and-so's wife. You are so-and-so's mom, okay? You're a parent, and in that context, that's your identity, right? You're a mom, okay? Nobody needs to know anything else other than you're a mom, okay? So then take that same PTA meeting. Later that night, you go with your partner to a work event. At the work event, who are you? You're so-and-so's wife. You're so-and-so's partner. Who do you identify as? When you go on vacation and somebody says, so what do you do? What's your answer? Oh, I'm a nurse. Oh, I'm a professor. Oh, I'm a mom. Oh, I work with humans. And so that is part of your identity, right? And what ultimately we're doing is trying to match the identity when we're having vaccine conversations. And so as healthcare providers, let's think of white coat syndrome. Like that's a thing, right? White coat syndrome is a thing. We know that people's blood pressures so high at the office, they go home, beautiful. And so we know that that's a thing. It's the same thing with vaccines. Whereas we're not taking their blood pressure perhaps, but they're already sensing there's a mismatch. There's a power imbalance there. And so really as healthcare providers, we have to identify that there is this mismatch of power. And we have to think, we want to match that conversation. So again, you're matching it practical, emotional, but now you're trying to also match the identity. And you're saying like, that person sitting there in front of you, maybe they're a mom, right? And that's what you're going to match to me. I remember having somebody saying to me, like, what would you do about, giving their child the vaccine? And I said, like, I'm a mom. Like, I give these vaccines to my kids. That's all they needed to hear. They don't need to know that I, work in vaccines and had for years. They don't want to hear that. They don't care that I'm a nurse. They care that I'm a mom and that I give vaccines to my kids, and I'm okay with that. Now, sometimes the question is, well, how do you even identify with somebody who's, you have a 30-year-old nurse and a 60-year-old patient, male patient, right? How do you match that identity? Well, you have, the 30-year-old, they probably have parents. They probably have grandparents, right? They have maybe kids. And the 60-year-old, let's see, they're probably a parent, a grandparent, they're have grandkids. And so there has to be a familial match, right? So you can say, my grandpa goes to Florida too, and I make sure that he has all the vaccines before he goes, and the HPV one is one I give him too, right? So there's that matching, that identity piece. So you're trying to find that out with other people, with your clients. So now when we take that, so really when somebody asks you, what do you do? What really you're doing, yes, it's your identity, but it's in a story. When you tell somebody what you actually do, you're telling them a story about yourself. And so that's where we get this connection piece, that storytelling comes in. Now, when we talk about storytelling before there was even the written word, that's how people communicated, right? With stories. And so it's older than science, right? Our life is one big narrative. Somebody says, tell me about yourself. Where do you start? You tell them a story, right? So it's all stories. If we think of it in terms of business, this is a great book, by the way, Stories That Stick, Kendra Hall. It is great just to say, like, how do you tell stories? Like, what's the whole impact of them? Ed Millett says, facts tell, stories sell. When you're in the business of healthcare, you don't think that you're in business and you're in sales, but you're really in sales. I remember when I first started in public health, 25 years ago when I was trying to tell people that breastfeeding was the way to go and you need a public health nurse to come out and visit you, I thought, man, I should have taken sales, because that's what I'm doing is you're trying to sell it. And how do you sell? Is you use stories, right? It's an essential business skill, right? Regardless if it's and it fits beautifully into healthcare. I mostly love what Brene Brown says. She says, stories are data with a soul. And so, when I'm talking about the very beginning of the presentation, when I'm talking about head and neck cancer, and I bring in the story of my best friend and her husband, like this is a story that is impactful for me, right? And me sharing that with somebody who's, my age, and they're out there, and I'm like, you like, this is happening. I see it. My best friend, 25 years married. And so that is a story, it's data with a soul. So I just love to, frame it, storytelling that way. And because it is really the best way to deliver research and data, because parents, they think they want science and facts, and actually they want stories and anecdotes, because people make decisions based in emotion and then they rationalize it. And so when we bring in that emotional piece and we connect with a story, it's more likely to have an impact for the person. Okay. All right. Now, what about misinformation and disinformation? Because, I know we all get this. It's crazy. Misinformation, just to define it, misinformation is incorrect information. Like they don't understand the science, perhaps. Which is, for example, I had somebody was talking about the HPV vaccine. They were like, oh, no, I don't need that because I don't get cold sores. So that's misinformation, because they thought, oh, okay, that was, HSV. They were thinking HSV, and they didn't actually understand what HPV was. So then that's a practical conversation, right? They need some data. They need some information. Whereas opposed to disinformation, where that is deliberately malicious information with intent to cause harm. And so, when we think about, AI and all this crazy stuff that happens out there, and people bring in these stories that are, oh, I'm not getting that vaccine because, I heard that will have my testicles will shrivel up if I get the HPV vaccine. It's like, wow, that's disinformation. That is somewhere like, that might be one where you have to ask, where did you hear that? Like, where did you see that? And ask for a little bit more information. And so, when we think about that, this is where you kind of have to decide, is it a practical conversation? Is it emotional? Do I need to disengage? Because sometimes, depending on the amount of emotion that's in there, like, no way, I'm not getting that vaccine, because, and it's like, maybe you want to clarify it, but there's no sense in engaging somebody who's really heated, because when the limbic system takes over, the prefrontal cortex doesn't work. So they can't make a rational just decision. So you're more likely better to say, I can sense that you're a little agitated right now, so perhaps we can discuss this at another day. And then you disengage from the conversation, because again, you have to take care of yourself, and there's no need to stress yourself out on engaging in these sometimes very stressful conversations. So let's talk about some scenarios, okay? Because it makes sense if we can put it into context, like where, and we could go with so many different scenarios, right? So you have a 22-year-old male and they're reviewing their vaccination status before going into placement. And so what might be something that the conversation might go, right? You say, this is great. Let's call him Jeff. Just say, hey, Jeff, this is great that you have all your vaccines. But the one here that's not on the list that I really recommend for you, just because, you are going to be working with humans, is the HPV vaccine. It's a cancer prevention vaccine. And then Jeff says, oh, I don't think I have that vaccine. Like, how many shots is it? How much does it cost? And they say, oh, it's just for your age group. It would be 3 shots or 2 shots, depending on NACI. And we can actually get it covered for you. And so then the conversation might go, okay, I'm not really sure about that right now. So I think maybe we can talk about that next time. Okay, maybe you're done, right? Because you have a busy schedule, you're going to leave it. So when we pick that conversation apart, we start with confidence. So you started just bringing up the conversation. You start with the conversation to say, hey, I recommend this. You're giving your strong recommendation. that about the vaccine. So now you're just bringing it into their head, like that awareness piece, right? A little bit of education. Then you're realizing their response to you is, how much does it cost? How many shots? That's a practical conversation. So you match the practicality, you give them the information. If maybe they said, oh, I don't even know, can you, like, I'm not really sure about that. Like, I don't really think so. And you do have time, you could maybe add a story. You're going to ask permission. You could say, can I give you a little bit more information about that? Can I give you a little story about this? And then, and kind of engage into that storytelling, right? And so there's kind of all that, just one scenario. Then let's use, for example, okay, you have a dad brings in a 15-year-old for their Tdap vaccine. Okay. So as you're getting the vaccine ready to give to the 15-year-old, you say to the dad, hey, Dad, guess what? I have a vaccine for you too. Dad says, and what vaccine is that? You say, oh, it's the HPV vaccine, it's the Gardasil. At your age group, I can guarantee you probably don't have this vaccine. And we see head and neck cancer, the incidence of head and neck cancer is really increasing around your age group. And so I highly recommend that you get this vaccine. I don't know about that. So then you could say, actually, when my son was in grade 9, him and I did the vaccine together. And, it's just kind of a fun mom-son thing to do. Like, so, okay, so let's stop this scenario. We'll pick this apart. Dad, I have a vaccine for you. Presumptive language, you're announcing, just bringing up the conversation, right? And then the practical conversation, what vaccine is that? They need information, you're giving them. Then what I did is I brought in my own story. And that story is actually true. I did do that with my son when he was in grade 9 because he wasn't indicated for the vaccine back then. And I said, this doesn't make any sense. Boys should have this vaccine too. And so him and I did it together. And so we brought in my own story, right? To say, this is what I did and make it normal. And I also bring it to that social identity piece that, okay, I'm a mom too. I have a teenager, this is what we did. Right. And so you're really normalizing the situation. Right. And then you can have, like, you have a 45-year-old brother. Okay. So let's say your brother's 45. So this is the scenario. After you're done the webinar today, you go and you call your brother and you say, hey, bro, guess what? I was on this webinar today. And, I really think you need to get this vaccine. Like, I'm sure you don't have it. And I'm like, I can't believe that the information shows the peak of head and neck cancer in 55 to 65-year-old men and 25 to 35-year-old men. Like, it's crazy. And so again, you're just starting the conversation. Who are you there? You're a sister, right? I care about you. I love you. You're starting the conversation. And so those are just 3 kind of scenarios, and that just to pick apart some of the concepts and how they all apply. And it does not take that much time. So the last little piece I like to see is cohesion. And really what cohesion is about is working as a team, right? We can't address the vaccine hesitancy alone. We can't increase awareness and education about HPV-related cancer, specifically head and neck cancer, and the vaccination alone, right? We have to do it as a team. We need to support each other. Work together. If somebody had a stressful conversation with somebody, we, talk it out. And really, we want to think upstream. You want to have these conversations before they even go and start looking up the information, right? So then they know that they can go back to you. Maybe they do look up the information, but they come back to you with their information, say, I looked this up. It said my testicles are going to shrivel up, right? And so, and you're like, oh my. And so then you can have these conversations because then they're going to come back to you. So that's a really important piece. The other piece about, focus on the process or the strategy, right? You're not going to get great at your first week of starting to bring this up and adding this to your practice every time somebody comes in. But really, you don't want to focus on that single outcome, right? Like, oh, I just screwed up. I'm not going to, on that conversation, I'm not going to do it again. No, you use that as a learning tool and a learning experience and get better at it. But again, making vaccines your normal talk in the clinical setting, using things like case studies at team meetings and saying, I had this conversation, like, what should I have said? Like, what would you have said? Right? It's kind of like after you get in a heated argument with your partner and then you go into the shower and you're like, oh, I wish I would have said that. It's the same kind of thing, right? You're having that conversation afterwards. So you can prepare, because I'm telling you, you probably know you've had the same conversation with 100 different people, right? And it's the same conversation. And so to get good at it is to talk about, what is everybody else saying? It's also to say, what story do you use? Like, can I borrow your story? Because if you want to borrow Tim's story, you certainly can. Tim, in fact, would like that. He said to me, I wish I would have got the vaccine. I wish I would have known about it. And then I'm thinking, like, this is what I do for a living. I wish I would have said something, right? So, you use somebody else's story if you need to. And even in the clinical setting, developing a vaccine philosophy or a campaign or something that's specific for. I know that Merck does have a lot of really great information that you could contact them and get some stuff about that's specific for it, and maybe focus on those men, these age groups or something, and promoting the vaccine and education and awareness around head and neck cancer. So really the key messages of today is we know head and neck cancers are on the rise, right? Especially in the forgotten groups. There are male, so think of the men that are in your life who are probably not vaccinated, and start that conversation, right? Prevention is the key. It's not about the vaccine, it's about the vaccination. So really focusing on that element. Engaging with compassion, right? So thinking I have to be empathetic, but then compassion is, what am I going to do about this empathy? Okay, yes, I feel awful for this person. How can I help them, right? And then connect through stories. So once you understand you're in like an emotional conversation with somebody, what kind of stories can you bring into the conversation, right? How can you connect with that person? Through their, and think about their different social identities that you can adopt that will help connect you to. And then start the conversation, right? Start the conversation, just start it. And so ultimately, when I started in vaccines, I actually, when I would travel, I would lie. I wouldn't even say I worked in vaccines. I would say I'm an esthetician, because my sister's an esthetician, and whatever. It was easy to adopt her persona. So I would say I was an esthetician because I didn't want to talk about vaccines. And then I started thinking, no, I have to be a champion, because who else is going to be a champion? So, when I travel, I typically don't tell people I'm a nurse. I don't tell people I'm a professor. I say, you know what, I work with vaccines. And so that, they might continue the conversation, or they might be like, oh, great, thanks. I'm going to go get a drink over here now. And so, you just never know. But that's, to become a super communicator, is what you have to do is start, right? Is just start having the conversations and then work with it. Take all the great conversations and the poor conversations that you've had, but you're going to work with it, and you're going to build, and you're going to realize like, oh, okay, this is a practical conversation. This is an emotional one. What kind of story can I add in here? And again, it doesn't have to take lots of time. It can be short and sweet. And so that's how we all can become a super communicator. And so this is a good time. If anybody has any questions, I would love to connect and answer any questions.
So if anyone has any questions, just enter the chat box, or we can unmute you to ask the questions, to ask Erin the question. I specifically love storytelling because I'm also a storyteller as well, but
Mhm.
probably not as good as Erin at all. Yeah, I love it, and this is actually what I'm bringing to China as well. Oh, I got
Mm.
somebody from Yuna. Thank you for your great presentation. Two questions she has.
Mhm.
You talked about transmission rate in HCPs. How can it transmit to them? As I thought HPV was transmitted primarily through the body fluid. Can it transmit through skin
Yeah.
contact with perinatal anal areas? And
Yeah.
then second question, you saw that in the chat that HPV vaccine hesitant clients say that they are told by the family doctors that HPV vaccine do not provide much protection as long as they are with one partner. They're told that HPV vaccine would be more effective if there is a new partner and there is now a risk for new exposure. What is your insight on this? And what would be the most appropriate way to address vaccine hesitancy in this case? That's a
Those are
great
great,
questions.
great
Yeah.
questions, great questions. So I'll start with the first one about transmission. It's direct contact, skin to skin contact with and a person who is infected with it. Now, the thing with HPV is that it can linger around for a long time in different areas, depending on. We don't actually know what, so if you're inserting, so if we think back to COVID, because it's droplet, but if we think, when we talk about aerosolizing, like what we don't actually know when you're inserting a catheter, into a urethra, like, is there some exposure there, right? Does it aerosolize at all? That's actually really questionable, even for dentists. So the Dental Association actually recommends that all their dental personnel are vaccinated with HPV because you're in the mouth where lots of head and neck cancer, and you're drilling, you're aerosolizing all the contents of the mouth. And so super important to be vaccinated just to protect yourself, right? Again, I always bring up we hepatitis B, hepatitis B, but that's our needle stick injuries. And so blood transmission, and we know that, but the risk is so low comparatively to HPV. So I guess the answer to that gets into the next question, which is about, doctors will say, well, if you only have one partner. Okay. Now, ideally, if we were don't ducks, they have one partner for life. Okay. If we were that person to only have one partner ever in your lifetime, that means the partner should only have one partner in their lifetime, and you've only had one partner in your lifetime. So friends of mine, they've been together since grade 6. Okay, sure. But what are the chances of that? That's pretty low, because even if I have a friend who had cervical cancer, was only ever with her partner, but her partner had been with lots of people, she would have benefited from the HPV vaccine, unfortunately, because she's thinking, well, I've only ever been with one person, but you have to also think about the person that you're with. How many other people have they been with? And is it just, sexual contact? Like, could be oral, could be anal, could be any contact. And so, we have to start thinking other things. I know that there are providers. I have a friend, he's gay, and I said, Drew, yeah, you need the vaccine. And he was like, well, my doctor said it's only for girls. Like, what? What is happening? So, I think that, again, part of being the super communicator is having these conversations. And that's really what we're doing, is we're still engaging in answering a lot of questions, because there is a lot of questions around the vaccine and that. So I hope that answered the questions.
The first one and the second one.
Yes.
Yeah, okay. Okay. So yeah, I hope so too. There's another question from Concerto. It's how do we approach conversation about vaccine injury?
So you mean the risk? I think that you mean risk, like about so usually when we talk about, the vaccine, there's always risk, right? There's risk for not having the vaccine, and there's risk, very, 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 very minimal risk with getting the vaccine, right? So sometimes you talk about, okay, so if this is where you could bring in, when we talk about risk, like the injury is, I usually say, I can assure you this vaccine has been out since 2006. It's been given to basically every country in the world and millions of people. And I can assure you it is extremely safe. So it could start there, okay? Where you're giving because if the conversation is a practical conversation, that's getting a story into the practical conversation, because you're making it, the data and information more, you're just bringing it, you're making it easier to understand, right? Sometimes we can say, you're getting, well, I'm scared about when you talk about risk benefit, so you could say, can I just tell you like some recent data that just came out actually the beginning of 2024 in Scotland, they went back to people that were vaccinated in the 80s and 90s. And so now when they were 11 and 12 years old, and now they're in their 30s, the people that got the vaccine when they were 11 and 12 years old, 0 people have cervical cancer in their 30s, 0. And so, that little story, but that's data with the soul, right? I gave that data, been able to take a whole huge study and put that into just a quick little story to say, I'm telling you, it's safer to get the vaccine. Absolutely, hands down. It's an anti-cancer vaccine. Yeah.
Great. Thank you. Thank you. There's 2 more questions coming.
Great.
Is there evidence that you have HPV in your body? Getting the vaccine will prevent it from resulting in cancer.
So that data, it's starting to show up right now to say the evidence is there, that it won't, that you've already been exposed. And so how likely is it that it will, rear its ugly head? So we have to think of it's not just the vaccine that, causes cancer, or like the vaccine doesn't cause cancer, but the antigen causes cancer. And so, it really is not protective that way for the most part, right? It's if you're exposed to it again. So let's just say you're exposed to one of the serotypes that causes head and neck cancer, like 18 or 16, and you already have that in your body. So there's, like, again, very minimal protection. So your body's already cleaned it up. It's tried to get rid of it. It has some memory. You get the vaccine. So now if you're getting exposed to it again, that's where the protection is, right? It's not to say, oh, I was protected. I had sex, with somebody who guaranteed, like they had HPV, last month. I'm getting the vaccine now, and now I'm going to be protected. That's not how it works, right?
Right.
But if you don't get any cancer or genital warts or anything from that, say, exposure, getting the vaccine, if you're exposed to it again, that's where the protection lies.
Right. Yeah, Marianne is thinking about your friend Tim. Yeah.
Yeah.
So another question, Heather, from Heather. I am a nurse educator for public health, and I find when I train staff, once those immunizations conversation become emotional with parents, many staff members don't want to engage as they don't like confrontation. So how do you help them to support these nurses, those nurses, ooh, jump up, those nurses to have those conversations? Must go to the data and skip all the other steps you discussed. Most goes to the data and skip all the other steps you discussed.
Right.
I
And
find it's true too. Yeah.
you're right. And so the problem is, if you just start spitting facts at people, you're not matching their what the conversation is about, right? It is an emotional conversation very much. And so what I find is that it's really important to listen. What are they worried about? It's like, wow, is it correct to say that you are fearful about the vaccine itself right now, right? Or you're reiterating the conversation back to the person. Can you tell me more? Can you tell me where, and you're getting the clients to talk more, because because what I find, you're right, what happens is providers will start throwing out their information, right? And so again, they're not listening. You're listening to respond and not to understand. And so to really listen, to understand, asking those questions, can you tell me a little bit more? What part of that are you worried about? Like, what is that worry? And so sometimes what happens is that the parent, they actually talk themselves out of it, right? They actually realize that they're being irrational with their conversation. And then they kind of go, okay, well, okay, like what this is that, remember I said that experience where I said, the person was like, well, what would you do? That's when it happened, is when I started asking more, and I was saying, yeah, I get it. Like I'm a mom too. And asking a couple questions. And then she said, I don't know, what would you do? So I matched her social identity. She didn't see me as a nurse. And see, a lot of times, if the nurse goes into the conversation with, I am a nurse and I know what I'm talking about, you're not going to win, You're not, like, it's not a win-lose thing, because you go into the conversation with, let's have a conversation. That's it. You're
Yeah.
not making them get the vaccine, because the pushiness is not going to work. It's just trying to understand what the problem is, and then you insert a story that might support that their worry, right? After you've
Right.
really understood what the conversation's about.
So Erin, is there a good resources scenario for nurses to role play or practice when they are training for this work from
You
Heather?
know, the best thing to do is to work together as a group. There's no, online, I mean, I have done resources. Actually, I've developed 3 modules about vaccine communication, or one's about vaccines, the other 2 about communication. But one thing I did with my group is what we did is we actually did, it's not, like a study, but we did anecdotally, when people came in and they were exempting from vaccines for school, we made a list and we said, okay, what vaccine is it? And what was the reason? Right? And it was just like, we're just like, what's the reason? We came back, wrote it down, and then we would bring it into our team meetings, and we would have a specific section where we'd talk about, okay, what'd you do? And what we're seeing. And one thing that blew me away was the amount of people that are still hesitant. They don't get the vaccine because of the MMR vaccine because of autism. And it's like,
Right.
whoa, I can't believe that's still a thing. And so then you can start to have these conversations. Okay, well, what would you say? What would you say? And just throw out like case scenarios, right? Like,
Right.
when I brought the case scenarios up, just like throw them out, right? Just
Right.
and make them actual, like ground rounds, So
Right. Right. Right.
we would do that to
That's
try to
great.
help them. And I also,
That.
yeah,
Uh-huh.
one other thing is that, if there's somebody in the clinic who's really good, like I had one nurse, she could sell a ketchup popsicle to a woman in white gloves. I'm telling you. She gave more vaccines in 1 year than all of my other nurses combined. And it was the way that she did it. And it was fascinating just to watch her. And so sometimes if somebody's really, really good at it, it's to get somebody else in there and just have them watch them and watch
Right.
what they do. And it's like magic. So
Right.
that's a couple
That's
ideas.
great. That's great.
Mhm.
Oh my goodness. You probably have a laser vision that you know about Tiana was talking about, like what else is, unique consideration in communication that require approaches that are
Yeah.
different from mandatory vaccines. So you answered that as well. So that's it. I think it's pretty much time we need to wrap up. So just over to you, Barb,
Thank
to wrap
you.
up this webinar.
Erin, do you mind stop sharing your screen?
Yep, sure.
Thank you so much, Erin. That was incredible. I think you came with that exact same passion that you had when you
Yes.
were at the conference, and everybody really appreciated it. So I think it's the same thing for today, that we have the same passion that came through, and the stories that came through. So
Mhm.
I just want to give a little reminder to people that we're going to be holding a couple of more webinars coming up at the end of October, and that's going to be on the topic of respiratory infections. And then we're going to have another webinar in November about the new updates from NACI about RSV. And we are also going to be having a few other webinars. So please check our website, and we'll be sending out communications to CHNC members. So thank you again, Erin. We're really happy to have you present with us again today. And thank you to Merck for supporting this webinar. Please remember, when you get the email at the end of this, when you get the email from us about completing the survey, and follow us on Twitter, Facebook, Instagram, and LinkedIn. So thank you again, and
Thank you.
wonderful rest of the day.
Thank you, everyone.
Thank you, everyone.